Welcome to AETCM, the Emergency Medicine Channel. So, 78-year-old female presented to the emergency with the complaints of breathlessness. On initial primary assessment, airway patient was talking in one full sentence and there were no pooling of secretions in the airway. Airway was patent. Next, coming to breathing, patient had a saturation of 94% on room air with respiratory rate of 25 per minute. In view of the labored breathing, we started with oxygen mask of 5 liter oxygens. And coming to the circulation part, patient had a BP of 140 by 90 with heart rate of 78 per minute. At this point of time, two IV cannulas were put in and blood samples were taken. And next, coming to disability.
What is the problem in all these parameters you are told? You are told patient is having breathlessness, there is tachypnea, there is hypertension, there is heart rate is 74. Which parameter is odd in this group?
Respiratory rate.
It is 25. That is high. Patient is having breathlessness. What do you think? Is there a problem in this parameter? Do you think any problem in that parameter? What is heart rate here?
78 per minute.
If somebody is having breathlessness, tachypnea, what will be the normal heart rate what you are seeing in emergency room?
It will be elevated.
Be very high.
Very high.
Maybe 100, 110. That is not there. That response is not there. Yes. So what all causes can produce bradycardia with breathlessness? It's not bradycardia. It is not that expected change is not there.
Patient can be on a beta blocker.
Okay, that is commonest cause is patient may be on beta blocker. Or anything like that, digoxin, diltiazem, verapamil. Okay. Then.
CKD patient with hyperkalemia.
Okay, CKD patient with hyperkalemia can also have bradycardia. Then. Hypothyroidism patient with pericardial effusion, bradycardia is one of the important findings. Somebody is having hypothyroidism, pericardial effusion, she'll have all features and bradycardia will be there. And if the pericardial effusion is massive, then also you can have sometimes bradycardia. And pneumothorax, tension pneumothorax,
bradycardia.
Okay, they are all dangerous conditions, but common myocarditis, some sort of myocarditis, not all. Myocarditis, normal response is tachycardia, but if it involves the conduction system, it can produce bradycardia also. Okay. So you have to think that something odd is there in your history. That's why I am telling you.
Okay. So next, coming to the disability, patient was fully conscious, GCS was 15 by 15 and pupils bilaterally reactive responding to light. Next, coming to exposure, patient was febrile and GRBS was 180 mg per DL.
Why you are looking at the people in this patient? He is having breathlessness.
To see if people...
You are in a robotic way, you are seeing everything, not thinking why you are looking.
During any IC bleed kind of situation, respiratory depression.
IC bleed, respiratory depression means that is reduced breath rate.
Yeah.
No? Here it is increased. Breathlessness is there. Now, what is there when you in your mind when you are looking at the pupil?
To say about the
Something
brain activity.
is there, or you just
brain
as a routine you have checked it?
To confirm the neurological parameter and also the brain activity.
No, I am asking whether you are routinely looking at the pupil and telling pupil is normal, or something is there in your brain and mind. You are looking for any abnormality in pupil. Any breathlessness can be associated with anisocoria or not. That is my question. You have looked for people, look for symmetry. My question is, any breathlessness can have anisocoria. Neurogenic pulmonary edema, you can think patient can have raised ICP, pulmonary edema, dilated people can be there. Okay.
In the myasthenia gravis crisis,
Myasthenia gravis, what will happen to the people?
people is normal.
Peoples are normal. And I am asking anisocoria. It is very specific question. Horner syndrome.
Horner.
So a patient who is having breathlessness, Horner syndrome is there, then there is a possibility of tumor in the upper lobe. Okay. So when you are looking for a finding, you should know why I am looking. That is very important. Blindly don't tell people is normal, rate is normal, like heart rate is normal. It's all routine case. But when you are presenting, you should know why I am looking for this finding. Okay. So we are always looking for anisocoria. That is, we are ruling out tumors in the upper lobes, that is Pancoast tumor or Horner syndrome, that is produced by the tumor.
So now, like primary survey, after finishing the primary survey, we're coming to the adjuncts of the primary survey. In the adjuncts of the primary survey, the ABG was showing no acid-base disorder, sir.
Okay. What acid-base disorder you are expecting in this patient?
Any other type 1 or type 2
Type 1 respiratory failure. Then what acid-base disorder you are looking? Type 1 respiratory failure can be there, but what ABG finding you will see in that?
In type 1 respiratory failure,
What do you look?
Alkalosis.
Alkalosis. You are looking for alkalosis. If that is not there, it's okay, but you are looking for that finding. Somebody is having tachypnea, you can have washout of oxygen and washout of carbon dioxide, oxygen can be increased, and he can develop respiratory alkalosis. You are looking for that. Specifically, you are looking for that. Otherwise, why should we take an ABG? This patient, it is not required. Okay.
ABG wasn't showing any respiratory failure or any acid-base disorder, sir. ECG was showing a normal sinus rhythm itself.
What you are looking in ECG is who is having, somebody is presented with acute onset of breathlessness. What all things you are looking for?
Sir, any cardiac, like ischemic change?
Okay, you are looking for an ischemic change. Okay.
Next, to see if there is any like pericardial
Low voltage
complexes
in ECG
to
is
be
second thing. Then.
And apart from that, any arrhythmias?
Arrhythmias you are looking for, because tachycardia can produce problems in reduced output, but here heart rate is already normal. Then you have to look for pulmonary embolism. That is the most important thing. Other things all are there. Whatever you told is a routine thing, we are looking. But you have to specifically look for pulmonary embolism findings. Yes. What are the findings you look for?
In pulmonary embolism, initially most common would be seeing is the tachycardia.
Tachycardia is the most common.
And then the pattern like RBBB pattern or right ventricular strain can be seen most oftenly. Or the specific pattern of Q1, ST3.
S1, Q3,
S1, Q2.
What is S1, Q3, T3?
S1 is the prominent S wave in the lead one, and in the Q wave prominent in the third lead, and T wave inversion in the third lead. This combination would be the S1 QT3
When
pattern.
will you tell the Q waves are significant? All Q waves are significant in ECG, or when will you tell that Q waves are significant in ECG?
More than one, like in the QRS, Q wave amplitude more than the
25% of the following R wave. Suppose R wave is 10 squares, at least more than 2.5 squares depth it should be there. Then only you can tell it is significant. And at least 2 consecutive leads you need to have same change. Suppose only lead 3 Q waves are there. What will you do to know whether it's a significant change or normal variation? How do you check it?
in the opposite.
You ask the patient to take a deep breath and take an ECG, that will revert most of the time. Okay. So isolated lead 3 Q waves are very, very common. But here the finding is S1, Q3, T3. Okay. That is also very rare, not very common. Okay.
Next, coming to the secondary survey, the patient is a known case of type 2 diabetes mellitus, hypertension, CKD, and these conditions. Patient was on regular medications, and patient had complaints of breathlessness for last 5 days. which was gradual in onset and progressive. No history of any orthopnea. But patient complains increased breathlessness while lying down and gets relieved by sitting.
It is orthopnea, no?
You
told there is no orthopnea.
Patient has complaints of orthopnea.
Okay.
And
What is orthodeoxia? Is it same or different? What is that?
Saturation. Decrease in saturation.
Increase in saturation and decrease in saturation on sitting up. Okay, where will you get that? You see a lot of patients here. What is that condition?
sitting.
Hepatopulmonary syndrome. Okay. They have this problem because of shunting inside the lungs. Okay.
So this patient came with complaints of increasing worsening breathlessness over 5 days, which orthopnea present, and PND was absent. There is no PND, and there is no any history of fever, cough, chest pain.
Basically, what is the difference between PND and orthopnea? If you know that, you will not tell like this. PND is absent, orthopnea is present. That's what you told. Correct? Now it's a basic mistake. You told PND is not there, orthopnea is there.
Yes. PND, like.
Which is severe form of breathlessness, PND or orthopnea?
Orthopnea.
It's all basic things. I'm not telling you it is required for an emergency medicine PG. Which is more severe, PND or orthopnea?
Orthopnea.
When you have orthopnea, no need to comment about PND. Because already, when he is lying down itself, he is having problems because of the fluid overload. Other one is the early phase of the disease. PND will progress to orthopnea. Okay, a patient who is having orthopnea will not have PND because he is already not able to lie down. Okay.
And patient had no any history of complaints of fever, chest pain, cough.
Okay.
Next, coming to the systemic examination, patient is paler and no stress. Pallor present, sir. No icterus and no any lymphadenopathy, no clubbing. Next, coming to the specific examination, systemic examination in respiratory system, patient had normal vascular breath sounds and bilateral basal crypts were present.
Okay.
Coming to the circulatory system examination, patient S1, S2 heart sounds heard, and on auscultation there was pericardial rub.
Pericardial rub.
Huh? Like friction.
Friction rub. How do you differentiate? You are told already there is crepitation, bilateral crepitation. How do you know that it is pericardial, lung crepitation or pericardial rub?
Location.
Location, everywhere you get no crepitations. How do you differentiate? Pulmonary crepitations and pericardial rub. How do you differentiate?
With inspiration, expiration.
You ask the patient
To stop breathing and we can.
You don't get any crepitation means that is a problem from lungs. If still it is present, it is from heart.
This history, like we went forward getting an X-ray done initially. In X-ray there was no any signs of fluid overload.
Okay.
And I think normal cardiothoracic ratio was present.
Okay. What is a normal cardiothoracic ratio?
1 is
When
less
will you
than
tell
50%.
the heart is dilated?
If it is more than 2,
More than 50%?
More than.
Okay. 0.5.
Next, on getting the echo, during the echo study, we could see that there is a fluid, there is a pericardial fluid.
Okay. Is it massive, mild, moderate?
Categorization wise, moderate. It was moderate.
Okay.
So,
is it clinically significant or not clinically significant?
Clinically significant patient was.
Patient is having breathlessness. Okay.
So then next, further the evaluation wise, the patient was sent for the routine blood investigation to see if the causation of this pericardial fluid, but there are no any increased infective markers present, and the patient had no any autoimmune or
What do you think from clinical finding? You have got a patient who is having some breathlessness, anemia, pericardial effusion is there by echo. BP is normal, no? BP is normal.
yes sir.
Okay. Normally, pericardial effusion, what will happen to BP?
BP should fall.
BP normally should
Should
fall.
fall.
It is not fallen. So there is no clinical significance. She is having breathlessness, that is definite, but it is not producing any tamponade-like features. Okay, what is the feature of tamponade?
In feature of tamponade, first the central venous pressure will increase because of dilated neck veins will be present. As cardiac output decreases, the systolic blood pressures will reduce, pulse pressures will become narrow, and the heart rate will also reduce.
What is the triad called as?
Beck's triad.
Where else you get similar finding?
Pneumothorax.
Okay, pneumothorax, tension pneumothorax also you get similar finding, but the name is not Beck triad. Here it is Beck triad. Okay.
And here the third point will be muffled, reduced
Muffled
heart
sound. Okay. Are you getting a muffled heart sound here?
No,
We are not. Okay, that's okay. So she is having pericardial effusion, not having hypotension, shock, all these things, and heart rate is only 78. What are the possibilities?
As earlier discussed, hypothyroidism.
Hypothyroidism is the most common cause for pericardial effusion, which is not having like tamponade-like feature, but bradycardia. If she is not on beta blocker, she is on beta blocker.
Yes, for hypertension related, she was on beta.
Beta blocker. So that can mask sometimes the finding. Okay, so we have to be very careful in interpreting this result. Okay, but still hypothyroidism is a strong possibility. Okay.
The next other thing would be to do a diagnostic.
What other possibilities? Leave one of the possibilities hypothyroidism. Anything else?
Autoimmune.
What is the age of the patient?
78.
70 years autoimmune diseases are not very common. Even if it is present, the severity of autoimmune diseases will drop down after 40 years in a female patient because of the reduction in the estrogen levels. Okay, normally autoimmune diseases in female reduces after like 40 years, 50 years. The incidence will come down. Okay.
Next, we have to rule out if any drugs causing the pericardial.
What drugs she is taking?
She is on no specific history here found.
So we cannot tell that.
Causes. Yes.
What else? What are the other possibilities for a patient who is having pericardial effusion, not very symptomatic, heart rate is not very much increased? What are the other possibilities? Viral pericardial effusion may be a possibility. Post-viral infection, some patients can have pericardial effusion. They may not be so much symptomatic like bacterial pericarditis. Tuberculosis? Tuberculosis is one of the strong possibility because they may not have so much finding like bacterial pericarditis. Okay, they have only mild type of symptoms. Okay, what do you do now?
So right now, for diagnostic, we can send thyroid.
What is the thyroid function test? Is it done?
Not done, sir.
What are the count?
T4 is 1.2. It's done, sir.
TSH?
TSH 2.3.
Okay, so hypothyroidism is ruled out.
Yes, sir.
Other possibilities, counts?
Counts were written 7,000 WBC and CRP was 6.
6 only.
6.
Anything else? Albumin? Creatinine?
Creat, as is a CKD patient, creat was elevated, sir.
How much?
Serum creatinine was 2.94.
So is it possible? What is the urea level?
Urea level for 69.8.
Is it possible that patient can have uremic pericardial effusion? What are the typical findings of uremic pericardial effusion? Uremic pericarditis, uremic pericardial effusion. What are the typical?
Chest pain.
Chest pain? Is there or not?
Is there?
Chest pain is there or not? Uremic pericardial effusion is one condition where you don't have chest pain. Then it can have bradycardia. Then so there is a possibility. I am telling it's a possibility. If a patient is having uremia, but here urea is not very high, but we don't know what was the previous values. So one of the possibilities uremic pericardial effusion. They will not have much finding like bacterial pericardial effusion. Minimal symptom, minimal signs will be there in uremic pericardial effusion. Okay.
Next, we can run the diagnostic test for the
Anything else is there in the
causation.
This
In
one,
this case, rest
everything is
normal. All the blood tests, electrolytes and LFT, RFT.
normal.
LFT is
Albumin, what is the albumin level?
3.4. So
Okay, that is also normal. Okay. Now what do you do?
now first, to relieve the symptomology, like if it is mild, we can start with NSA
Okay.
treatment.
So can you give NSAID in this patient or not?
No, sir, already CKD patient.
Already patient is having CKD, you don't want to aggravate the problem. So that should be avoided. Then can you give steroids? Steroids are one of the indicated drugs in pericardial effusion due to this chronic inflammatory conditions. Why should we give steroids?
To reduce the inflammatory reaction, to reduce the production of the fluid.
Suppose it is tubercular effusion. Why should we give steroids?
Flow will become to syndicate.
What is that condition called as?
Fibrotic brands.
Constrictive pericarditis. Till fibrotic bands will produce, then afterwards patient will have constrictive pericarditis. So if conditions like chronic inflammation like tuberculosis, fungal infections, we have to give some minimal dose of steroids along with the mainstay treatment. Okay. So in that condition you have to give, otherwise massive pericardial effusion due to malignancy, to relieve the symptom also you can give steroids. Otherwise steroids are not indicated in many types of pericardial effusion.
Next, other thing would be doing pericardial.
Is it done here or just left it?
We have done pericardiosynthesis, a diagnostic pericardiosynthesis,
Anything is there?
No, sir. All gene expert was negative. Even the KOH smear was negative. Gram smear was also negative. No any infective.
Okay.
Cytology was also done, but no any atypical cells were seen.
Okay, so mostly it will be due to what? Here we have ruled out many conditions, like you have ruled out your hypothyroidism, infective parameters are ruled out. And what is left with in this patient, which can produce painless pericardial effusion? What is left with?
Uremic pericarditis.
It has to be uremic. If nothing is there in this patient, most possible diagnosis is only uremic pericardial effusion. Okay, uremic pericarditis leading to uremic pericardial effusion. That will have painless pericarditis and asymptomatic pericardial effusion. That is one condition which produce all the clinical finding will be masked. Okay.
So in this case, the patient was symptomatically relieved with diagnostic tapping, and further, as the patient was better, they had.
How do you tap pericardial effusion?
In the subxiphoid approach
Towards
the left shoulder.
Okay. If you have a monitor, you can. If you have an ultrasound echo, you can easily know you are penetrating the pericardial sac. If it is not there, how do you know that you are touching the heart?
We have to continuously keep cardiac monitor as such, so that if the muscle, if anything is involved, the disturbance in the
ectopics can come on the monitor. So that you have to monitor and do tapping. Okay. Yes. Tapping is required actually in patients who is having pericardial tamponade. Here we are using only for diagnostic tapping. Okay. What happened to the patient?
Patient was symptomatically relieved after tapping 50 ml of the fluid, sir. And in the diagnostic tapping, as there were no any confirmatory findings, patient was discharged as the
same. So there is no treatment required because it is a uremic pericardial effusion. Possibly there is no other findings got. Gene expert is also negative. Gene expert tell you what? What can expect from gene expert result?
It tries to identify the gene amplification of the Mycobacterium tuberculosis.
What else?
And also resistance to rifampicin and
okay. It is very important that rifampicin resistance can be picked up by gene expert. But if you go for PCR, it will only tell you that the bacteria is present or not. Okay. PCR is done?
No,
TB PCR is done?
Not. Okay. Only gene expert.
Gene expert is done. What is the advantage of gene expert over PCR?
Even the
PCR takes time. Okay. Gene expert is faster. Gene expert tell you that whether the organism is resistant to rifampicin. Other one is just telling that bacteria is present. Okay. What is the problem with this PCR and gene expert comparing with AFP? So it's mainly done in sputum, no? AFB
Yes.
and gene expert, PCR. What is the disadvantage? What do you think the disadvantage is?
In pericardial.
Anywhere. AFB, you can pick up the live bacteria, or recently like detected bacteria can be seen in the AFB smear or stain. Okay. Whereas PCR and gene expert, a small particle of the bacteria we are picking up. So even after many days of treatment, also this can be positive. If you do PCR in a patient who is already having tuberculosis and getting treatment, and if a patient is improved with their treatment, also PCR can be positive. So that is very important. Should not repeatedly do PCR after many days of treatment. But AFB can be done. Okay, what happened to this patient afterwards?
This patient got symptomatically.
So you want to tell something about
Yes, sir. Like there is a grading of the cardiac tamponade, like stage 1, 2, and 3. In stage 1, usually the heart rate and the central venous pressure would be normal, and in that the volume of the fluid, like estimated, will be less than 200 ml. In grade 2, the central venous pressure will be elevated, causing the dilated neck veins and heart rate, and here the mean arterial pressure will be dropping. That will be around 200 ml fluid estimation. In grade 3, more than 200 ml amount of fluid, here it will be showing the proper Beck's triad of hypotension, tachycardia, and increased central venous pressure with muffled heart sounds. Grading of the cardiac tamponades.
what is Dressless syndrome?
Dressless syndrome is a post-myocardial infarction.
Only post-myocardial
Any cardiac event, aortic dissection, trauma,
surgeries.
cardiac event leading to the pericardial fluid accumulation is
What is the
dressless.
treatment there?
Usually it has to be open.
Open.
And,
What is the treatment?
NSAID.
It's only NSAID.
NSAID is a dressless.
It's an
treatment.
inflammatory process. Okay, so only treating with NSAIDs are enough. Okay. Anything else? Want to add? Want to add anything? Okay. Anything else you want to tell?
Sir, actually regarding there is the grading in cardiac tamponade for the emergency medicine physicians. First we use the etiology grading, and we marked like we score etiology, we score the clinical presentation, and we score the imaging. Accumulating this scoring, we see if specific scores were given to each, and if there's higher than grade 6, then immediately the emergency physician can take the action of doing a pericardiocentesis. If they're normal, then wait and watch for 28 to 48 hours can be used, like the scoring systems can be used for this condition.
Okay. Okay.
Yes.
Thank you.